Health and Wellbeing Queensland acknowledges the Yagara and Turrbal people, the traditional custodians on the lands on which this podcast was recorded, and the traditional custodians on the lands and waters on which you are listening. We pay our respects to the Aboriginal and Torres Strait Islander elders past and present, for they hold the memories of the traditions, cultures and aspirations of Australia's First Nations people.
The main difference for a woman who's had a caesarean compared with a vaginal birth is really that they may not return to core exercises quite so early. But other than that, the recovery is not too dissimilar, and I do encourage women to be quite slow with returning to those higher impact exercises.
Hi, I'm Dr. Sam Manger, a GP and your host of this series, The Clinician's Guide to the First 2,000 Days, brought to you by the Queensland Government through Health and Wellbeing Queensland. Prevention across the first 2,000 days offers an opportunity for healthcare professionals to support generational health improvements. But preventative health will only be successful if it is done with confidence and empathy and an evidence base. Over the course of this series, I will be talking to some of Queensland's leading experts to explore how they discuss preventative health and how to create meaningful change for the next generation. Let's get started. Today, I'm talking to Dr. Sarah Thomas and Melissa Billiau on women's postnatal physical and mental health. Dr. Sarah Thomas is a registered psychiatrist at the Martyrs Catherine House, the state's first dedicated inpatient facility for new mothers experiencing perinatal mental health challenges. Melissa Billiau is an advanced pelvic health physiotherapist with over 12 years' experience. She's the clinical lead in a primary health clinic at Ripley Satellite Hospital. Thank you both for joining me, Sarah and Melissa.
Thank you for having us.
Let's start with a bit of core knowledge, good old physiology, Melissa. What physiological changes occur in a woman's body immediately after childbirth, and how does the postpartum hormonal state affect a woman's muscles, joints, and overall strength and ability?
Really good question. I'll sort of split it up into hormonal effects and then more of the musculoskeletal effects. So hormonally, there's a really big change that happens in that early postnatal period. So throughout the pregnancy, levels of estrogen and progesterone are significantly high, but once the baby is born, these levels do drop quite dramatically, which has a significant effect on the mum. These levels usually drop around that day 3, day 4 postnatally, and is one of the big contributors to those big uncontrollable emotions that can be seen at that time. The low levels of estrogen and progesterone will continue throughout that 4th trimester, so really right up until 12 weeks postnatally, but actually can even go a lot longer, particularly for mums that are breastfeeding or exclusively pumping. These low levels of estrogen contribute to low mood, anxiety, vaginal dryness, pain with resuming intercourse, musculoskeletal changes, the list could go on and on. So they're very, very significant throughout this time. Other changes that happen in that physiological changes that happen in that early postnatal period are, of course, the big musculoskeletal changes. Mum has had a growing abdomen throughout the pregnancy, which then drops once baby is delivered. Those abdominal muscles that have been stretched throughout that time obviously have to regain their tensile strength. They have changes to their posture, including increased lumbar lordosis. A weakening of glutes often happens, a weakening of the hamstring muscles, on and on. So quite significant changes that happen throughout that time. Throughout the pregnancy, our pelvic floor muscles have undergone a significant strain, with baby sitting right on that area. And then obviously with vaginal birth, they've undergone a very significant stretch. Up to, I think, 300% has been recorded increased length of the muscles. So obviously with a vaginal birth, there is that added stretch and in some cases trauma to these muscles and also the nerves in that area that can contribute to a weakening and a dysfunction of these pelvic floor muscles. We have very good evidence to support pelvic floor muscle training throughout the antenatal and the postnatal period to improve this, which in turn improves symptoms in bladder and bowel and sexual function.
Yeah, great. And we'll get back to management a little later because that is critically important, how we can help women recover from that, as you say, fairly significant period of their life. And you highlighted there the sort of diffuse role that can happen both musculoskeletally but also psychologically. And this brings us really to your area of expertise, Sarah, the two sides of the same dice that is the complex human, the mind and the body. What are the changes that we may not be able to see, those that are psychological? How prevalent is perinatal mental ill health and what's its potential impacts on both mothers and infants?
Perinatal mental illness is probably a lot more common than most people realise. We see postnatal depression in between 1 in 5 to 1 to 7 women. 1 in 5 women will develop an anxiety disorder across the perinatal period. Postnatal psychosis will affect 1 to 2 women in 1,000, and bipolar disorder affects 1 in 100 people in Australia, and often women will experience their first episode of a bipolar disorder in the postnatal period. So as Melissa discussed, following childbirth, there is a dramatic drop in estrogen and progesterone, which does lead to drastic mood swings and can predispose to developing symptoms of depression and anxiety. This is what we see when people talk about the baby blues. Often starts around day 2 to day 3, and often women will experience uncontrollable crying, sadness. They can have significant disruption to their sleep outside what is expected of having a brand new baby, and women can feel often quite disconnected from themselves and their baby. Generally, this resolves within 2 weeks, but if it persists more than 2 weeks, we start thinking more about, is this a postnatal depression?
So you said there 1 in 5 can suffer from sort of postnatal anxiety and depression, and then obviously smaller rates for the more severe mental illnesses. Is there a flip of that where there's some women who get better mental health?
Yeah, so there are some women who have pre-existing mental illness who actually see an improvement in their symptoms throughout pregnancy. I would say that they're generally not the people that are referred to me. A lot of the women that I'm seeing are women who unfortunately have ceased their psychiatric medications because of the pregnancy and have experienced a significant deterioration in their mental state secondary to this. So it's what we see a lot of, unfortunately.
So what's your approach to assessment for these women, and are there screening tools we can use for postpartum depression or anxiety or the other psychiatric conditions you mentioned?
Yeah, so the most commonly sort of used screening tool within the Australian healthcare system is the Edinburgh Postnatal Depression Scale. This is a 10-item questionnaire that asks women to rate their feelings over the past 7 days and is scored for a total score out of 30. This looks at symptoms of postnatal depression and anxiety and should be completed at the first booking visit and should be repeated in the second trimester. This is usually done by the midwives and obstetricians, but also GPs are able to do this. These tools should be repeated at least once in the postnatal period, around the 6 to 12-week mark, and should be repeated again later on in the first postnatal year. It's important to note that these are screening tools only. So if women are screening positive on a screening tool, they should be referred for further assessment. That assessment should be completed usually by a GP in the first stages, but can also be completed by psychologists, psychiatrists and other trained mental health professionals, depending on the settings in which these women are being seen.
Excellent. Are there culturally specific tools that one can use for First Nations people that also screen for these things?
Yeah, so there is a specific tool that's been developed and validated for use with the First Nations population, which is the Kimberley Mums Mood Scale. That's freely available online, and the Edinburgh Postnatal Depression Scale has been translated into a number of different languages, which again is available freely online.
Excellent. That's great. Thank you. And does the Edinburgh tool also include sort of risk to self, risk to child within the questions, or is that something we should add on top?
So the final question number 10, asks specifically around risk to self. If women answer positively to that question at all, so the Edinburgh will ask for a response out of 4 different responses and is a score between 0 to 3. If a woman scores 1, 2 or 3 around the question for self-harm, they should have further assessment prior to leaving the office in which they have completed their screening tool. In the postnatal period, we need to ask specifically around any thoughts around harming the children.
Yeah. Okay. Very important. Thank you. So if there are symptoms of postpartum depression or anxiety, what are the strategies and components of management, and who else should we be involved? You mentioned we might start with the GP as an initial assessment, which makes absolute sense. So what's the wider team and what's the management part of this?
So management will really be guided by the severity of the symptoms, but also the support and resources available within the network that a woman is in. So as with all mental illnesses, we always like to focus on the practical supports to start with, as well as sort of the biological care of these people. So ensuring adequate nutrition, sleep, although difficult with a baby, encouraging women to sleep as much as they can, as well as limiting their use of substances and exercising when safe to do so. For mild to moderate cases, psychotherapy is the first-line treatment for both depression and anxiety. There are a number of perinatal psychologists, but also public services which women can be referred to for specialist perinatal psychology support that can be accessed with a mental health care plan at no charge to women. For moderate to severe cases, often women will require psychotherapy plus medication. That medication, depending on the condition to be treated, we have a number of medications which are safe to use in breastfeeding. For specialist advice or for very severe cases, specialist advice should be sought. And we have an increasing number of perinatal psychiatrists in Brisbane with the advent of Catherine's House, but I would suggest GPs to all phone for advice if you're not sure what to do. In rural and remote areas, there is the EPIM service, which is a telepsychiatry service for perinatal and infant psychiatrists for women living outside of the metropolitan areas as well.
Excellent. You summarised those three core pillars, the lifestyle social factors, the psychotherapeutic factors, and obviously the pharmaceutical or medication factors. And I think it's worth saying, and I can have some anecdote here as a GP, that there is a lot of hope there because treatment is quite effective and women can get a lot of relief and improvement to their mental health. So it's important to highlight that. With the social part as well, do you find it quite important to support women in a sort of peer support or social connection or women's group or community sort of element? Is that often a part of your management plan?
Most definitely. We know that being at home with a newborn and a young baby can be incredibly isolating. And so having women increase their social connections, often through mothers groups, is quite an easily accessible way to access that social support. There are also a number of organisations that do peer support, specific mental health support. Peachtree is one of my go-tos. They run a number of different programs and they are a lived experience peer workforce, so are very helpful at supporting women.
Fantastic. That's Peachtree for the listeners out there. And what about the third wheel here, dads? So I'm a dad of three, so I had to throw this question in. So what about the new pressures on dads? Because obviously there's a huge amount of going on for the mother and the child, but what about those changes, pressures on dad, the changes to the relationship dynamics and the role that the partner can play in supporting this whole process?
Dads are often forgotten a lot in this space, which is something that we're trying to change. And we know now that up to 1 in 10 fathers will experience postnatal depression. Unfortunately for dads, really their experience of parenthood begins with the birth of the baby. They haven't really had the same experience of preparing for delivery of the baby like the mums have. So it's often a bigger adjustment for fathers once baby is here. Dads often are having to go back to work a lot earlier as well, so they have to very quickly adjust to the new roles and responsibilities within the household, but also juggling parenting and returning to work quite quickly. Dads also will vary a lot in their confidence in handling the baby and often will be quite anxious in feeding, bathing, settling baby, but they should be encouraged to do so because we know the benefits of having dad involved in caring for the baby, not only for building that bond with dads, but also the benefit of that on baby's brain development.
Yeah, absolutely. I think, do we know much about the sort of role of oxytocin in this? Because as you highlighted, the mother has the whole pregnancy to feel and get used to the idea of the baby, and there's that bonding hormonal connection that's going as well as the sort of psychological bonding, and that builds with breastfeeding and continued support. But with men, that's not around so much, and it takes a sort of 6-12 months to really feel a sort of deeper bond potentially.
Yeah, it often will take fathers a lot longer to develop that bond and attachment with their baby, which is why we encourage dads to be involved as much as possible, including helping with feeding where possible, but all of the tasks of looking after the baby, not only to help their bond with the baby, but also to help out their partner as well. Of course.
Yeah, absolutely. And it's good to somewhat normalise that process. You highlighted before the key pillar there of lifestyle determinants and lifestyle approaches, and there's significant evidence that things like physical activity and diet and sleep can improve mental health and physical health. And so when we consider that lifestyle behaviours can impact this so significantly, let's get a little bit of context, Melissa, if we can, about when we can use these approaches safely. What are the typical timelines for postpartum recovery, and how soon can a mother safely return to exercise after different types of birth, whether it's vaginal delivery or C-sections?
Yeah, look, it's really different for every single woman, and it depends on their experiences, physically during pregnancy, even before pregnancy, and what sort of things they were doing at that time as to how they can recover. That early period in the first sort of couple of weeks after having bub, it's really about adequate rest and not necessarily about doing anything in particular, but actually being forced to lie down and rest their body and allow their body to heal in the best place it can. This is particularly important for women who have laboured and birthed vaginally, but even for women who have had a cesarean, that supine rest is really very, very beneficial. It's important to, reduce the physical pressure on the perineum, especially if there has been a tear there with stitches. We want to avoid friction and pressure there while it's healing. It also helps to reduce the swelling and the inflammation that can occur in that area, particularly if we're just sitting all the time, as opposed to if we can lie flat, we really allow that to flow and get flushed out throughout the lymphatic system much better. The pelvic floor, as we said, is already a very weakened and stretched area, and the amount of weight down through that area, even if we're just standing for long periods of time, is really quite significant, let alone if you're including holding a baby and trying to settle a baby. So using that network around you is very, very important to allow mum to have that break. As we go on throughout the recovery time, after a couple of weeks, should start feeling a little bit better and the pain from birth is starting to ease and the swelling is starting to get better, and mum may want to then start engaging in a little bit more physical activity, which is wonderful, and we really encourage that. Just being mindful that, as we start to re-engage in exercise, it is really gradual, and listening to the body is really important. So as a very general guideline, I'll say sort of around 2 to 4 weeks, you could start doing some short walks, maybe around the block, maybe, 10, 15 minutes, but really, tuning into how your body is feeling, and if there's any of those signs of vaginal heaviness or pressure or bulging, then that's the indication that you've done enough and it's time to go home. And the best thing you can do when you get back home, as we said before, is to go and lie horizontal, maybe even with your legs elevated or a pillow under your bottom, just to allow all of that pelvic area to have a really good rest. And that only has to be for 10, 15 minutes, but can have a significant effect on the recovery as we start to get back into exercise. Throughout this early time, of course, we've spoken about the pelvic floor muscles as well that are really important to be doing regularly. And it's, coming into this 2 to 4 weeks, it is about starting to rebuild up that strength now. So working the muscles a little bit stronger and adding in, holds or pulses throughout this time is very effective for regaining that strength and functional activation. We also include exercises, just low-level exercises for back pain and thoracic pain that might be occurring with holding baby all the time and those sort of things, just recovering from being pregnant as well. So this is all very important in this early time. After around 6 weeks, we start to see that things are starting to feel much, much better and, you're feeling like you want to do a bit more, generally speaking. And we progress those exercises very gradually, but building them more into gravity load, adding more core exercises in at that time, increasing walking distance gradually, but still being very mindful of not doing anything high impact. We don't want jumping at that stage. Running at that stage is probably a little bit too much. And just as always, tuning back in and reflecting again, how is the body recovering and how is the body feeling? And obviously any of those signs of, it might not even be heaviness anymore. It might be signs of incontinence. Are those symptoms that actually that's too much? We need to bring that back. The main difference for a woman who's had a cesarean compared with a vaginal birth is really that they may not return to core exercises quite so early. But other than that, the recovery is not too dissimilar. And I do encourage women to be quite slow with returning to those higher impact exercises, even for a cesarean delivery.
Stay with us. We'll be right back to continue our conversation.
Health and Wellbeing Queensland's Gather and Grow program focuses on improving food security in remote Aboriginal and Torres Strait Islander communities in far north Queensland. We're working hard to build the capacity and capability of remote food stores and engaging with communities and community organisations to identify priorities and lead actions that will improve access to healthy food and drinks. Find out more on the Health and Wellbeing Queensland website by searching Gather and Grow.
And now, back to the conversation. You mentioned some really important principles there. The first being rest, which can be quite hard to any human to accept at certain periods of their life. As much as we may know we need it or want it, it's still hard to stop sometimes. So that's to be encouraged normalized, supported, celebrated, especially in those first couple of weeks. Then you mentioned around the 2-4 week mark, there'll be probably an organic sense that people can start moving more freely, and that's where you can start bringing holds and pulses and walking and a few basic exercises, like you mentioned, core exercises, but we're going to avoid the high impact exercises. You mentioned another principle there, which is really important, which is around tuning in. That listening to the body, that listening to the whispers of the body is super important, something we can all learn from. So that's a great sort of idea. When do you think, you mentioned the high impact might come a little bit later. Is there an average for, is that sort of 12-week mark or?
Yeah, look, it's a real very generalised guideline, but yes, around that 12-week mark is when we tend to see some of the hormones maybe starting to increase again, and we think, you're looking at a little bit more of a safer recovery time from musculoskeletal tissues, perineal tears, cesarean scars should be relatively healed and strong at that time. But this is all assuming the woman has that background exercise tolerance and is able to progress into that very, very safely as well. So we always recommend having a pelvic health physiotherapist review to allow that sort of really specific guidelines on how that recovery should commence and re-engaging of high impact exercise. But yes, as a general rule, we will say around that 12 weeks is when we can start to consider re-engaging in those higher level activities.
And what are signs that may either indicate that things are going well or they're not going so well? So you mentioned there around potential incontinence might sneak in or may not resolve. So what are some signs that we need additional support, particularly regarding C-sections or perineal tears or pelvic floor strength, as you mentioned, incontinence or the various other concerns a woman can have? Yeah,
I think the really big signs in those early periods, like we spoke about, is those vaginal heaviness symptoms, those pressure feelings are really important to listen to and take a break from and get further advice as needed, which might be a GP or a physiotherapist. Of course, any signs of incontinence is really important. That's getting looked at and getting referred really early on as soon as possible. Even urinary frequency or urgency should be addressed, as well as any sort of bowel issues if there's any fecal urgency, particularly if there was any element of a 3rd or 4th degree tear where the tear has developed into that anal sphincter. It's important that we're really asking the patient about those symptoms and getting those looked at really early on. From other warning signs, I guess in terms of the recovery of a cesarean tear or a perineal tear, we need to be asking those infection questions as well, making sure there's no untoward pain or signs of odour or any pus or signs of infection in that area and getting those addressed as soon as we can.
Yeah, so fever, general unwellness, as you say,
Absolutely.
Pain, discharge increasing and so on. Are there any, you mentioned Kegel exercises before, so are there any specific movement recommendations or exercise recommendations that seem to be sort of perennially true, or there you go, pun intended, I suppose, but is that can be helpful regardless of where a woman's at? So are there specific pelvic floor muscle exercises that you would just recommend pretty much for most people?
Yeah, absolutely. So really quite early on, even in the hospital, if everything was going well, once the catheter is removed, if a woman does have a catheter, it's great to start some gentle movement in that area of the pelvic floor muscles. And that might be just really gently sort of trying to engage and squeeze the muscles around the back and the vagina and then letting it go. And this can help with, blood flow and swelling in that area, which of course helps to promote healing. And it's not doing, 10 repetitions 5 times a day or anything like that, but just a couple every now and then just to keep that area moving can be really beneficial in that early time. As I said, after a couple of weeks, we're then starting to really more focus on the strength side of things, and then we might be adding in quite structured regimes, which might look like, exercises, try and do them 3 or 4 times a day. The regularity is really important. They're a small muscle group, but they need to be exercised regularly, and adding in those holds. And we often use Bub's age as a bit of a guideline as to how long you might be holding for. So if Bub is 1 week old, we encourage the woman to try and hold the muscles for 1 second. And as Bub is 2 weeks old, we hold the muscles for 2 seconds. Working up towards 10 repetitions in a row is a very good guide. Usually around that 3-4 week mark, we sort of add in those stronger pulses where it's more of a try and like squeeze, lift, let go, squeeze, lift, let go, which is more around those side of coordination of the muscle.
Yeah, fantastic. And as you say there's sort of, rather than being regimented or too strict around doing it X number of times a day. It's when opportunity arises, by the sounds of it. So, you might be boiling a kettle or you might be doing something like that. Now's the time for my exercises. And so make it a part of your life.
Yeah, absolutely. But it can often be the thing that gets forgotten about too, as busy mums are busy looking after a new bub. And,
of course,
yeah.
And sleep deprivation.
Oh, yes.
Yeah. So are there any resources you would often recommend around that, Melissa, specific to exercises? And then Sarah, I'll ask you about mental health resources. But is there often you find handouts or reliable resources or even, dare I say, reliable YouTube channels that maybe a pelvic floor physio set up or things like that?
Yeah, I mean, we really are so fortunate with the increased availability of digital resources that are around now. A lot of the handouts that we use are from the Continence Foundation of Australia website, and they're all online, so women can access them themselves. Or Pelvic Floor First is another very reputable website which goes through guidelines on recovery back into exercise with a weaker pelvic floor and gives ideas on what exercises are suitable at different stages of the postnatal period. There are a number of apps on our smartphones, and if you put in just a simple search of postnatal recovery or postnatal workout, there will be a stack that come up. Empowered Motherhood is a program by an Australian physiotherapist and includes pregnancy-safe workouts and postnatal workouts. And of course, as you said, good old YouTube absolutely has some not so bad guidelines on recovery and little routines of what women can do in those early postnatal periods just to start moving, which is so important.
Yes, it's interesting. YouTube has a bit of a bad rep, but the reality is there is some bad stuff on there, a lot of cat videos, but it's also, there are some very qualified physiotherapists, for example, who do set up channels and do make some reasonable recommendations. So if we can filter those for our patients a little bit, that can be helpful. And Sarah, what about for the mental health side of things? What support systems and resources? You mentioned a few already around peer support, which is fantastic. But for that perinatal mental health period that health professionals can access or that the public can access?
Yeah, so it's really important for healthcare professionals to be aware of what's available in their area because it does vary even from the north side of Brisbane to the south side of Brisbane. But we are very fortunate. There's a relatively new service available that's called For When. It's a national service that can be accessed by families, carers and healthcare professionals and helps navigate people to the right support, really. So healthcare professionals or patients can ring and describe what's happening for the mum and they'll be directed really to the right place. My two really favourite online resources are COPE, which is the Centre for Perinatal Excellence. It has a wide range of information for both healthcare professionals as well as patients, including a really lovely section for fathers. My other go-to resource is Panda, the Perinatal Anxiety and Depression Australia, which again is a fabulous resource for both families and healthcare professionals. Panda also operates the only national perinatal mental health helpline, which is open for extended hours from Monday to Saturday and is staffed by volunteers as well as trained professionals. So again, families, patients, as well as healthcare professionals can ring that helpline. The Gidget Foundation is another really valuable online resource that although they provide telehealth psychology sessions, they also have free online groups which women can join, and these are often peer support-led groups, and they have a wide range of them depending on how old women's babies are. So again, another really valuable resource.
That is fantastic. It's very heartening to hear actually how many support services there are, especially in that telehealth peer support component, because obviously a lot of people in Queensland are not necessarily based in a major city. They're based in regional hubs or rural and remotely. And so having those online/digital/telehealth services available is super important. So that's really great to hear. Pregnancy and obviously postpartum, the period afterwards, is at very least a highly special time and many, I would think, a fairly sacred time of life. And that brings in a wide variety of different beliefs and practices around this period of life, especially from different cultures. And Sarah, how do we address sort of cultural beliefs and practices that may influence how people perceive mental health or the postpartum period or pregnancy so that we can make sure our advice is helpful, hopefully valuable, but also sensitive and tailored?
It's really important for us working within this space to recognise that sort of our Western model of pregnancy and postnatal period is often very different to other cultures and how they really prepare for parenthood and manage the postnatal period. Often there is significant stigma attached to mental illness within other cultures, and so often women will not feel comfortable discussing their symptoms and can often present a lot later than other women that we are seeing, and often with more severe symptoms. So being really mindful around asking specifically what women are experiencing. And often women will not feel comfortable talking about mental health symptoms in front of other family members as well. So that's something that should always be considered. Something that I do see, unfortunately, quite often is the lack of interpreter use as well. So for anyone working with women of culturally and linguistically diverse backgrounds, interpreters should be offered for every consultation, especially when talking about some of the more complex mental health symptoms, including thoughts around suicide. It's really important that we ensure that women are understanding what's being asked of them. The other really important thing I think to note is when we're looking at women and how they are functioning across the postnatal period, for us what may seem like symptoms of significant perinatal mental illness, including not wanting to really look after the baby. Often within certain cultures it's quite normal for the extended family to take over the primary care of the babies, especially in the early stages, and that's quite normal and expected. Something I saw really commonly in COVID, which I hope we never have this experience again, was with our closed borders. I had a lot of women from different cultures who had significant perinatal mental distress because they weren't able to have their families over here with them, and that is really devastating for women who can't have that expected cultural experience of parenting.
Yeah, another key points there, as you mentioned, there's clearly going to be a difference in diversity in beliefs and practices, and so important just to be aware of that full stop and be aware of the potential stigma that may be aligning around, you said, around potentially perinatal mental health concerns. And it would seem to me that normalising it, inverted commas, with a tool like the Edinburgh tool that you mentioned helps just bring it into routine practice. So it's not seen as something that they're being singled out for. This is just part of routine care. We just screen for this and we check for this, which is a good thing to do. And as you say, using an interpreter, absolutely key. You mentioned there that sometimes there can be pressure on women and they may be with a family member. So this is a nuanced question, but do you as a psychiatric clinician sometimes ask to see the woman alone if you feel that there may be that element to it?
Definitely. I always like to start by asking the women that I'm seeing what they would like. If I'm getting the sense that there are things that I need to talk about with them on their own, I will often ask at the end of the consultation, do you mind if I have a few moments with you on your own? Obviously, that needs to be done really delicately, especially with women who are in domestically violent relationships. So it's often a very nuanced way of conducting these assessments.
Excellent. Thank you. So now if we zoom out a little bit from the really important, obviously, the mum and bub and dad sort of perspective and think about us, the health providers and the health professionals who are helping. This can also be, a difficult period for us as well to help women through this. This can be a lot of stress, a lot of, as you say, a nuance to it. So what are some self-care strategies for healthcare professionals working with perinatal populations and to maintain our own well-being? Perhaps, Melissa, we could start with you and Sarah.
Look, it can be a really challenging time, and it's obviously filled with a lot of emotion and a lot of prioritisation for looking after bub, and often, mum can be forgotten about. And I think, when we are dealing with these big emotions and these big challenges, if a mum's experiencing fecal incontinence, for example, then, she's very, very distressed. But, as a healthcare professional, I think managing that within a team is sort of the best way, and being able to appropriately debrief and, have those collaborations with your team on those complex patients, on how you can better support them and support each other, which I'm very fortunate to have out at Ripley.
Yeah, as Melissa mentioned and yourself, Sam, working with this population can be incredibly emotive and challenging at times, and we have the benefit of working with families in the highest of highs, but also alongside that, there are the lowest of lows. And it's really important that healthcare professionals have regular clinical supervision to talk through the difficult cases that they do work with. Some healthcare professionals end up, and I'd say that this is quite common, having their own psychotherapy to cope with the stresses of this work. We should practice what we preach. It's incredibly important for us to be really looking after our physical well-being and prioritising the lifestyle factors of adequate nutrition, sleep and exercise, and limiting our reliance on unhelpful coping strategies such as substances, including alcohol.
Don't go anywhere. Our conversation continues after these messages.
Connecting to You is a free text messaging service that provides timely information, tips and health check reminders for new Queensland parents and carers to keep their child healthy and strong. Encourage parents and carers who are in your care to sign up for free weekly text messages with information, tips and health check reminders for the first 5 years of their child's life. Find out more at childrens.health.qld.gov.au.
And now, back to the conversation. And that point there around there's no shame in needing help yourself is a really key one. It's to normalise that actually it's probably a good thing if most health professionals did have their own person that they connect to, relate to, whether it's a therapist or a peer support network or another colleague, as you say, or a supervisor or so on. So a key component of all of our health going forwards.
Most definitely, and it helps you be a better clinician.
Absolutely. The lived experience itself and the reflection as well, crucially important. All right, so let's start with a little bit of core knowledge, good old physiology. So Melissa, what physiological changes occur in a woman's body immediately after childbirth, and how does the postpartum hormonal state affect a woman's muscles, joints, and of course, therefore, overall function and strength?
Yeah, thank you, Sam. I mean, that's just such a big question, and there's just an enormous amount of physiological changes that occur in that woman's body immediately after childbirth. One of the big changes that occurs is quite a significant drop in our hormonal levels, particularly of estrogen and progesterone. These have been quite high throughout the pregnancy, and then usually around that sort of day 3, day 4, we get this really quite significant drop in those hormones, which has a number of effects, but often around that time we can see those big uncontrollable emotions that can be linked in with those hormones. So those low levels of estrogen and progesterone continue throughout that 4th trimester, up until 12 weeks of postnatal period, and actually can go for even longer in a mother that is breastfeeding or pumping. And this is particularly relevant when we start talking about return to exercise and the effects of these hormones on the musculoskeletal system. So estrogen within our muscles and our joints allows for an increased collagen content in our connective tissue. This increased collagen provides a lot more elasticity through our muscles and tendons and our ligaments, which is actually really protective for reducing the risk of tearing or damage. So when these estrogen levels are low in this postpartum period, our muscles have a lot more stiffness to them, and therefore if we are to go out and engage in sort of higher intensity exercise, they're a lot more likely to tear in that early period. If we think more about the pelvic organs, such as the bladder and bowel and the uterus, they're a lot more stiff as well. So, again, if we're engaging in those higher impact exercises in that early postnatal period, there's just that higher risk of a little bit more trauma to that area. So encouraging that gradual return is really, really important in that time. Other big physiological changes, obviously the most obvious one is increased stretch on the abdominal muscles throughout the pregnancy, and then after birth those muscles have to return to some sort of state, which takes time and is often something that can be a little bit distressing to mums, so we need to do that really respectfully. The term that's often used to describe this stretch of the muscles is a DRAM, or a diastasis rectus abdominis muscle, and I think often as health professionals you might hear terms such as the muscles have been torn, or there's a widening or a separation of these muscles, and I think we need to be really careful with how we're describing what has happened here, because it can be quite distressing for the mum. We know that usually around that 6 to 8 week mark, these muscles will have recovered really, really well. And actually, the functional implications are very low if there is a slight thinning of that. It's the linear alba between our sort of six-pack muscles that causes that appearance. The main effect that we understand now from the evidence that has come out is that it really is aesthetics disturbance as opposed to anything functional from a low back pain point of view or any implications with, bladder or bowel health, those sort of things. The other big physiological change is our pelvic floor muscles. They've undergone a huge amount of strain, just through the pregnancy alone with the extra load on that area. And then, of course, if there's, a vaginal birth, even if a woman has laboured and may not necessarily have progressed to a vaginal birth, the strain on that area is very, very significant. But of course, if a woman has had a vaginal birth and maybe with a perineal tear or or an episiotomy where they cut the tissue, the extra trauma to that area is increased. So these muscles are really important for protecting our bladder and our bowel function and our sexual function. So it is important that we're restoring those muscles to a good level of strength and function after we have bub.
So, Liz, you mentioned there around the sort of timeline for recovery and building back in some form of exercise, 2 to 4 weeks gentle and then up to 12 weeks high sort of impact. Where does sex fall into that category? Because obviously that's quite important for many people.
Wonderful question. I mean, such an important part of the relationship dynamic, which we know changes quite drastically after you have a baby anyway. And I think penetrative intercourse is certainly one thing we'll talk about, but I think re-engaging that relationship dynamic and making changes where needed to still be intimate with each other, but maybe not necessarily around that actual penetration is really important consideration, and using, just cuddling and holding hands and all those sort of nice things that should happen, can happen within a relationship. Typically, I guess if a woman is feeling well, we'll say, once your vaginal bleeding has stopped and if you've had a vaginal tear, you've had it checked for healing and recovery and those sort of things, which can be around that 6 to 8 week mark, you are safe to resume intercourse. Many women do not feel ready at that time, and really making sure we're supporting them that actually that's absolutely okay, and these are conversations you need to have with your partner, and communication is really essential at this time. But when a woman does feel ready, I do encourage them to use a really good lubricant and a good amount of lubricant. It's quite normal to be a little bit dry just from the hormonal changes, but also just the concern or worry around resuming that intercourse can add to that. And I encourage the mum to be in control, that she's controlling the speed and the depth and making that as a positive experience as possible. And it's not unusual to feel a bit of discomfort the first few times, but the important thing is that that's getting better as they continue to engage in intercourse. And if it's not, then they need to be asking for some further assistance, either from their GP or a physiotherapist.
And a pelvic floor physio is the right place to go for that as well?
Yeah, absolutely. So a pelvic floor physiotherapist, can help, whether it's an overactive pelvic floor that might be contributing to some of these symptoms, and it might be just teaching the woman to be able to relax those muscles and let go instead of tensing and holding on during that time. Sometimes other interventions are required, which might be things like vaginal dilators, just can help to passively stretch that area, or sometimes vaginal stimulation using a TENS machine can be really effective if it's more from a pain response that might be occurring.
So thank you so much, Melissa and Sarah, for joining me today for this very important topic, and thank you for your excellent work.
Thanks very much.
Thank you.
Today we've been talking to Dr. Sarah Thomas and Melissa Billiau about the physical and mental health changes that occur for women post-pregnancy. For more information on today's topics, visit the Health and Wellbeing Queensland website at www.hw.qld.gov.au. If you've liked today's conversation, be sure to subscribe for future episode updates. We'll see you next time on the Clinician's Guide to the First 2,000 Days.